Hello, good afternoon. The webinar is going to start in 10 minutes. Thank you very much. Hello, welcome to this webinar session. The webinar will start in 5 minutes. Good afternoon and good evening. Since we are different countries participating in this webinar, in fact, we are about 15. My name is Susana Palacios, and I am the Global Marketer from Laboratorio Skin. I would like to welcome you to this webinar, Don't Be So Sensitive, Controlling Dental Sensitivity. As you know, dental hypersensitivity is a common oral health problem that requires a specific treatment. This webinar is an update of different aspects of this dental problem, and especially on the different options for its management. We are pleased to count on the expertise of Dr. Eilish Lynch and would like to thank her for having accepted our invitation to give this webinar. Dr. Eilish Lynch is a clinician who runs her own private practice as a specialist in periodontology and implant dentistry in the west of Ireland. Dr. Eilish Lynch is graduated as dentist from University College in Cork. She was awarded her Master's in Clinic Dentistry in Periodontology with distinction, and also the membership in periodontology from the Royal College of Surgeons of Edinburgh. Dr. Eilish Lynch is also a member of the British Society of Periodontology and the Irish Dental Association. Concerning the webinar organization, just informing you that it's going to last about 45 minutes. And at the end of this webinar, there will be a time for questions. You can see in the top right part of your screen a question mark sign. Please simply click there and write your questions. We will try to answer all of them at the end of the session. Nothing else from my side. Only thank again Eilish for the opportunity of this webinar session. I pass you to the word to you, Dr. Eilish.
Thank you, Susanna, and good afternoon. Greetings from Limerick. It's 1 o'clock here, and well done if you're giving up your precious lunchtime to attend this webinar. Thanks to Unicum for inviting me to speak to you today on this topic of dentine hypersensitivity. As Susanna mentioned, I'm a periodontist working in a town called Ennis in the west of Ireland. However, as part of my specialist training at the Queen Mary University in London and the Royal London Dental Hospital, I had the privilege of working with Professor Robert Hill, who was a leader in the field of biomaterials, and Dr. David Gillum, an expert in an area of dentine hypersensitivity. And during my time at Queen Mary, I was involved in laboratory-based research to develop toothpaste components to treat hypersensitivity. As a clinician, this did give me an appreciation for the challenges faced by industry to develop products to manage this often troublesome condition. Now, as clinicians, we are regularly asked by our patients as to how well over-the-counter products work for the management of many problems that affect the oral cavity. And when it comes to the management of hypersensitivity, in order for us as clinicians to provide the best possible advice that we can, we need to first understand what hypersensitivity is, what are the products at our disposal to treat it, and how well do they work, if they work at all. So how well do we understand it? Well, there's a very interesting paper which I referred to a few times in this presentation, and it was produced by the Canadian Advisory Board on Dentine Hypersensitivity. And they provided a questionnaire study, and they asked 331 dentists and 211 hygienists a series of questions to see if there were any knowledge gaps in relation to hypersensitivity, and the results were very interesting. They found that only 7% of dentists and 5% of hygienists correctly identified the primary cause of hypersensitivity. 60% of respondents incorrectly identified gingival recession as the most common cause. 85% of dentists and 94% of hygienists incorrectly cited toothbrush abrasion as a reason for continued tubule exposure. And 50% of dentists and 73% of hygienists reported incorrectly that fluoride was the most popular desensitizing toothpaste compound. Now, when we look at our Canadian colleagues, do we think that we would have done any better? With that in mind, let's have a look at the mechanisms underlying the development and management of dentine hypersensitivity. So what is it? Hypersensitivity has been defined as a short, sharp pain arising from exposed dentine, in response to chemical, thermal, tactile, or osmotic stimuli which cannot be explained as arising from any other form of dental defect or pathology. It is usually diagnosed after other possible conditions have been eliminated. It is therefore a diagnosis of exclusion. Now, I find this definition very helpful when patients complain of sensitivity-like symptoms. I will ask them, well, does the pain go away when the stimulus, such as a cold drink, is removed? If it lingers, then it's unlikely to be sensitivity. And so how do we diagnose it? We have many tests at our disposal to help diagnose sensitivity. The air jet, the cold water jet, other thermal tests, a dental explorer, periodontal probe, radiographs if needed, percussion testing, assessment of the occlusion. In particular, we're looking for evidence of a traumatic occlusion, such as premature contacts, non-working side interferences, and bite stress tests. So this careful examination is necessary in order to exclude conditions that can also cause pain in the oral cavities, such as dental caries, cracked tooth syndrome, a fractured tooth, sensitivity after a recent restoration, pulpitis, and palato-gingival grooves. So which of our patients are most likely to develop hypersensitivity? So we're looking for signs when we do our examination of loss of enamel, denudation of cementum, gingival recession, tooth wear, which can be caused by erosion, attrition, or abrasion, periodontal disease, and of course its treatment, and patient habits such as grinding, the wearing of intraoral jewellery, which can cause wear of enamel. But remember that not all exposed dentine is sensitive. Acid erosion is a primary cause of hypersensitivity. So if we don't understand the problem, how therefore can we manage it? So how does it develop? Well, to understand how industry approaches product development to manage hypersensitivity, we need to know how it develops. And the currently accepted theory for dentine hypersensitivity is the hydrodynamic theory. And this theory proposes that external stimuli, such as your cold drink, ice cream, hot, tactile, or osmotic pressure, when applied to exposed dentine, cause dentinal fluid movement. This fluid movement stimulates mechanoreceptors near the base of the pulp and may trigger a pain response. So, for example, when you have an ice cream, and I must say it's a particularly nice and warm day here in Limerick, the cold may cause fluid to flow away from the pulp, and this activates intradental nerves. And it's this fluid movement in the tubule which flows quicker in response to cold that stimulates that sensation of pain. 75% of patients with hypersensitivity complain of pain on receiving a cold stimulus. And studies which have looked at extracted teeth of patients with sensitivity have shown that there are a greater number of tubules per area, and the diameter of those tubules are greater than in patients who have no identified sensitivity. So if we look at this image, what do we see? Well, we see a tooth that's in a labial position. It's a Miller's class 2 gingival recession. There's no keratinized gingiva remaining, and there's exposed root cementum. But why does this patient not have a sensitive tooth? Gingival recession isn't causing sensitivity. We need two things. We need what are called lesion localization, and that's dentine exposure. So recession exposing cementum can lead to wear of that cementum and expose the dentine. But we also need lesion initiation, that's acid erosion. So what is this? Lesion localization occurs when the dentine is exposed, but for the second phase of the development, lesion initiation, we need to bear in mind that not all exposed dentine is sensitive, and this can be due to acid erosion because it removes that smear layer and it opens up those dentinal tubules. Indeed, Martin Addy has stated that the question has been posed as to whether hypersensitivity is actually a tooth wear issue. And as I've mentioned, studies showed that patients with hypersensitivity have a greater number of tubules per area, and the diameter of those tubules is greater than in patients who have no identified sensitivity. Remember, if the tubules are not open, then we don't get sensitivity. And the episodic nature of hypersensitivity, meaning why does it come and go, may be related to the presence and absence of the smear layer. Acid erosion therefore appears to be the predominant factor in the development of hypersensitivity. And in this SEM image, you can see on the left we have open tubules, and the right tubules that have been closed due to the presence of the smear layer. And it's this smear layer that's a critical determining factor in the development of sensitivity. So with that in mind, let's go back and think, is this a common problem? Well, yes, it is, particularly for our periodontal patients. There is a degree of difference between studies, and some studies estimate a prevalence of up to 69% of the population, and I guess that depends on the population under study. Females seem to be affected more than males, and this could be related to better oral hygiene practices. And the buccal surfaces of canines and premolars also appear to be more greatly affected. This could be related to their predilection for gingival recession. There appears to be a peak prevalence in the 3rd and 4th decades of life, so that could be due to increasing gingival recession as we get older, but also it could decrease with age after that due to the deposition of secondary dentine. So how do we manage this problem? Well, the first thing is to try to prevent it, remove those risk factors. Patient education is very important, especially in relation to oral hygiene techniques and the diet. The use of desensitizing toothpaste and mouthwashes are an important first-line treatment. The use of in-office varnishes, bonding agents and restorations can provide a more immediate effect in office, and surgery where required. How do all these products work? There are two main ways that these products work. And industry approaches the management of hypersensitivity based on these two ways. The first one is through nerve desensitization via the use of potassium salts. This involves blocking nerve activity by depolarizing the nerve synapse in the pulp and preventing the conduction of pain impulses. And this would have been the traditional way that toothpaste have been used to prevent sensitivity. The other way is through tubular occlusion, remembering Pozzoul's law. So with this aim, it's to reduce the flow of fluid in the dentinal tubule, and the aim is to mimic the natural desensitization process that occurs through spontaneous tubular occlusion. Now, as mentioned, the tubules have to be open for pain to occur. If we remember Pozzoul's law, the flow of fluid through the tubule is proportional to the radius to the fourth. So what that means is if you change the radius of the tubule, then you can dramatically change the flow of the fluid. It doesn't have to be completely changed to dramatically change the flow. And this has been a very important target for industry. Also, studies have shown that the number and the diameter of the tubules increase from the outer dentine to the inner junction with the pulp. What that means is that with increasing tooth wear, the sensitivity increases. So how do we manage this problem? Sensitivity toothpaste represent 8 to 10% of the global toothpaste market, and one would start with a desensitizing toothpaste. However, the choice of over-the-counter versus in-office management is determined by how severe the pain is. And while there are obvious advantages to using over-the-counter products in terms of ease of both access and expense, they can take up to 2 to 4 weeks to be effective. So in-office bonding agents, for example, might provide a more immediate effect. Now, there is an overwhelming array of products on the market, as listed here, that can be essentially broken down into their mode of action being either nerve depolarization or tubule occluding products. And if you look at this table, you probably are familiar with many of those names, but did you ever question how they work and why one company can have a few different products It could be that the active ingredients in those products is different and working differently for patients. So what works for one patient may not work for another. So they're based on potassium salts, as mentioned, as these provide nerve depolarization, strontium salts, which provide tubular occlusion, fluoride, which is interesting because there's not a huge amount of evidence as to how fluoride works, but we know that it does work in reducing sensitivity, and it forms fluorapatite, which is more resistant to acid attack than hydroxyapatite. Arginine, which is a more recent development. Bioactive classes, which is an area of research that I've been involved in. One of the properties of bioactive glass that make it particularly interesting is that it adheres to or sticks to the tooth surface and may therefore action as a slow release device. It may not work as quickly, but it does release ions in the hours afterwards, which is very useful. Which works best, and do these products work? This is a photo I took of some of the products which I've pulled from my cupboard in my own office for managing sensitivity. And when we look at it from an evidence-based perspective, it becomes very clear that a positive result for every ingredient or desensitizing product tested to date can be found. This makes it a bit difficult for us to compare studies and draw meaningful conclusions. So as the studies can be quite different in how they're set up. So what can we draw from all of this? Well, there is no ideal product. The duration of relief is variable. Regular application is required. Hypersensitivity usually reappears over time due to the effects of toothbrushing, acid challenges, and product degradation. The literature shows a positive result for every ingredient or desensitizing product tested to date. Could this be due in part to the placebo effect or Hawthorne effects? And the Hawthorne effect is where just by the act of somebody being enrolled in a study, they modify their behaviour, which can in of itself lead to improvements. As clinicians, it's important for us to question how these products work, understand the science behind them. Are they based on potassium or on tubular occlusion? And I guess the same can be said for any product that are presented to us. So what is the future? Well, we know that fluoride toothpaste is effective in preventing caries, and toothpaste are a very useful way to deliver beneficial ingredients, such as in the management of sensitivity. And going back to my own research, the introduction of a multifunctional toothpaste would therefore seem to provide a very ideal solution to treat dental disease. However, something that becomes clear when you're in a laboratory is that a fundamental tenet of producing any new pharmaceutical with multiple actions or ingredients is, however, that any additives should not interfere with the primary mode of action. Basically, don't interfere with the anti-caries effect of fluoride by adding other ingredients. Because this could denature that product, that active fluoride effect. And this can make the production of new toothpaste more challenging. There is no single cause for sensitivity, and therefore there is no single therapy, there's no gold standard. However, not all is lost. There are products out there that can function as a smart multi-component product, such as the Kin range of Sentikin toothpaste, which I'm a fan of, and they have a mouthwash and a gel. The toothpaste and mouthwash contain 5% potassium nitrate and 1450 parts per million of fluoride. So they do both decent nerve depolarization and tubular occlusion, and they also have the added benefit of vitamin B5 and vitamin E to protect the gingival tissues. So as I mentioned, the advantage of these products is that they can have a dual effect by nerve depolarization and tubular occlusion. And studies have shown that they can also work more quickly. Traditionally, we've been told to use toothpaste for up to two weeks to see effects, but there are studies that show that they can work in less than 48 hours. Now, one product that I'm particularly a fan of for more severe dental hypersensitivity is the gel. The Sensikin gel has 10% potassium nitrate, and this can be applied directly to the tooth after brushing at night time. If, like me, you've told patients to dab their toothpaste on, that's an incorrect use of toothpaste. It should be brushed twice a day, and it can take time to work, but the gel can be dabbed onto the tooth after brushing. So how do we incorporate these products into our strategy, our management plans for our patients? Well, we need a systematic and a structured approach to the management of hypersensitivity. And I refer back to that Canadian board paper, which had a very useful algorithm, which I've adjusted here. And it involves, first of all, screening the patient, obtain their history, ask them, are they experiencing hypersensitivity, as it tends to be underreported. They may have sensitivity and not mention it. They might think it's something they just have to put up with, or they might be using products that aren't effective for them. Examine the patient, get that diagnosis correct, confirm your diagnosis, initiate management, remember that diet advice in relation to acid exposures, remove the risk factors, and provide oral hygiene instruction. Follow your patients up. Use desensitizing technique, such as toothpaste and gels, which will be the first line treatment. They're non-invasive, inexpensive and effective. And follow up. If that pain is persisting, reconsider the diagnosis. If it's not persisting, review them regularly as they can come back. Don't delay if surgery is needed. For example, this exposed root might be sensitive, but the main problem is the lack of keratinized gingiva and the obvious root exposure. And this is a problem that could deteriorate. So while the tooth might be sensitive and products can be useful as an adjunct, the main treatment that's required here is a connective tissue graft. What are our take-home messages? Well, I've mentioned how good history taking is important for the diagnosis, and also is the identification of at-risk patients. You don't need to wait for the sensitivity to develop. Remember that tooth wear and dentin exposure could make somebody more vulnerable to later sensitivity. Look at patients who have a thin gingival biotype who will be more at risk of gingival recession. Periodontal disease in itself exposed can lead to recession, but also its treatment. When considering products to recommend, understand how they work, as I mentioned about dabbing on toothpaste, but they need to be used regularly for 2 to 3 weeks. They shouldn't just be stopped if there's some relief achieved. There is no one-size-fits-all in this era of personalised medicine. What works for one patient may not work for another. Follow up your patients. Because of that smear layer that was mentioned earlier, hypersensitivity can be episodic in nature. Reduce the acidic exposure. So remember, this is a tooth wear issue also. So no swishing of fizzy drinks around. Use sugar-free gum, as this can increase the pH in the intraoral environment. Don't overbrush, as this can lead to gingival recession. Don't brush after an acidic challenge. So normal brushing of the teeth with or without toothpaste has actually relatively little effect on erosion unless the environment has recently been acidified. Manage your patient's expectations. Be proactive, raise awareness. Often it's the patient who mentions it, or they accept it and they don't mention it at all. So by understanding the action of products and by considering not only just the etiological and predisposing factors, but also monitoring the patient, we are providing the best care that we can for our patients. And thanks to Pamela and the team at Palmex and Unikin. And I'll hand it back to Susanna. Are there any questions?
Okay. Thank you, Eilish. That was really interesting and educational. So thank you again. Here are some questions. What's the most frequent case of dentin hypersensitivity in your practice?
Well, Susanna, as a periodontist, I would see a lot of sensitivity with patients who have a history of periodontal disease, but also post-treatment. Now, fortunately, that sensitivity can be short-lived, but not always. So really the most common that I would see would be with patients with a history of periodontal disease and its management, because root planing does, as we know, up to 70% of patients with periodontal disease who have been treated have sensitivity. But I know in general practice, particularly where more cosmetic treatments are provided, tooth whitening can also contribute to short-term sensitivity in a different manner to that caused by acid erosion.
Okay, and is there any case in which dentin hypersensitivity can affect other treatments?
Well, yes, in relation to cosmetic treatment, patients who are at risk, who are interested in having tooth whitening, hypersensitivity toothpaste are very useful to use in conjunction with their tooth whitening products. There are whitening products that have a lower percentage of carbon peroxide, as low as 6%, in conjunction with their potassium nitrate or fluoride tubule occluding products. So patients who are undergoing tooth whitening would require desensitizing products such as the mouthwash, the toothpaste and the gels.
Okay, is there any specific agent that is more effective for mechanically induced sensitivity versus chemically induced sensitivity?
Well, I guess the 10% potassium nitrate works very effectively and more quickly. So you're, like with any product, any pharmaceutical agent, you're determining what you're going to use based on the patient's need. So for patients who have more severe sensitivity, I'll recommend the Sensikin gel, for example, because of the stronger 10% potassium nitrate. And for milder cases, I might just recommend a product that contains less potassium nitrate, the 5%, for example. Or the mouthwash can be very useful because patients aren't rinsing afterwards.
Okay. Can Sensikin be used before or after whitening? What would be your recommendation?
If a patient already has sensitivity, then I will be using it before. If they don't, then I would use it during and after.
How long does it take to overcome hypersensitivity?
Well, it's episodic in nature. That means it comes and goes. So that would be very much dependent on, for example, the diet of the patient. If they have a more acidic diet, then they're going to have more sensitivity. While the products are very helpful, you would really want to also use it in conjunction with modifying their diet. The products say that some of them can work within 48 hours. Often they need to be regularly applied for up to 2 weeks, but that doesn't mean that they're just a help. It doesn't mean that the sensitivity is gone forever. They need to be regularly applied, and again, it's individual to the patient as to how effective they work. Because if the diet is particularly acidic, they're going to have sensitivity, and it's going to be an ongoing issue. So it's up to us to guide our patients with that and give them diet advice. Use diet sheets, for example, to explain to them what aspects of their diet are more acidic, so citrus fruits, carbonated drinks.
Many patients come with severe dental hypersensitivity. So how can the product help to manage this problem?
Well, regular application, not using it as a quick fix. I guess the purpose of today's presentation is to look at what hypersensitivity is. So if we educate and inform ourselves, then we can educate our patients, and by understanding the products, by explaining to the patient that this is a product that will help you, but you need to understand what the condition is, why it develops. So it's used in conjunction with correct patient education. Patients like to think that if they buy a product and apply it, that's the end of it, but they also have to work to limit those risk factors.
Okay. In the case of a periodontal treatment that could produce also sensitivity, and in which you also need chlorhexidine to prevent infection, how do you face the treatment for both situations?
Well, I warn all of my patients, my periodontal patients, that they're at risk of developing hypersensitivity, but I don't necessarily recommend the sensitivity products straight away. So if they require a chlorhexidine product, then I will recommend that. If they develop hypersensitivity, then I would recommend that they use a sensitivity toothpaste and a chlorhexidine mouthwash. So I'll use the products together rather than using two different, for example, a Sensikin gel and a chlorhexidine gel, or a Sensikin mouthwash and a chlorhexidine mouthwash. I'll provide a prescriptive plan for the patient using both products if required, and there's no evidence that one product denatures the other product, so they can be used together. So I'll advise the patient regarding what works best. They may not necessarily have to use a chlorhexidine containing product just because they have periodontal disease if their oral hygiene is good.
Okay, what's the mechanism of action of potassium nitrate to prevent the pain?
Nerve depolarization. Now, to be honest, if we look at the science, we don't actually know if that's exactly how it works. It is asking a lot of the potassium ion to travel down the dentinal tubule against the flow of the fluid to reach the nerve and to depolarize it. That's how we theorize that it works, but we don't actually know. So by using a product that has a tubule occluding effect in conjunction with the potassium nitrate, we think that that allows it to be more effective. But we know from clinical studies and trials that the potassium nitrate products work, but we don't actually have a whole lot of science to show us that they do exactly work how we think they work. The science isn't brilliant, it has to be said. It's a challenging one, but what is positive is that we know that the products work.
Okay. Does potassium nitrate have any adverse effect?
When it's used in a toothpaste component, there haven't been any adverse effects. I mean, toothpaste in of itself can, for some people, particularly ingredients like sodium lauryl sulfate, can be irritating, but it's more likely that if there were any side effects or problems from a toothpaste product, it's not likely, there's no evidence, it's not likely to be the potassium nitrate itself. It's more likely to be a different ingredient in that toothpaste, and that ingredient is usually the SLS. So if you have patients who might be reporting not sensitivity, but maybe that their mouth is sore, they may have a condition called desquamative gingivitis. It's usually the SLS that is the problem, and I would use an SLS-free toothpaste. And there are desensitizing products, toothpaste, that are SLS-free.
Okay. According to your experience, for severe sensitivity, can we use the 3 products, and how long does it take until we can see the result?
I would start off, I suppose, like with any pharmaceutical agent, with the lower percentage, so your 5% potassium nitrate toothpaste and mouthwash, and then if I would review the patient, and if that's not meeting their needs, then I would step up to the 10% Sensikin gel. But if that wasn't effective, you could use something in office as well, such as a bonding agent. And if that wasn't effective, then I'd probably go back and reassess my diagnosis.
Okay. Here is another question. Mainly in developed country, people are still not aware about oral health problem. How can we advise them to manage dental sensitivity?
Sorry, Susanna, I missed the start of the question.
Yeah, I'll repeat it again. Mainly in developed country, people are still not aware about this oral health problem, sensitivity. Do you have any advice of how to manage in this kind of people?
So you're saying that there's a general lack of understanding in the population?
I think so. I think so.
Okay. It is true, but I do think that there have been some very good marketing campaigns on the TV to guide patients, and I do think marketing has been very helpful. Hot things hurt, cold things really hurt is one that springs to mind. But I suppose as clinicians, that's our job, really, isn't it? To educate patients, not to wait for them to tell us their teeth are sensitive, but for us to ask them, have you ever experienced sensitivity? Many people have it, but they think it's something that they have to just put up with, or they might self-treat with products that aren't particularly effective, or they might just avoid certain things. So they might deprive themselves of ice cream, for example, thinking that I have sensitive teeth, there's nothing I can do about it. So through education, but also I guess industry has had a role in promoting products, because it is desensitizing products are a big global industry. So marketing and clinicians both have a role in educating our patients about this product.
Okay. Here we have another question. I think that it was already answered, but just in case, what is the realistic time frame from moderate the sensitivity to be relieved with the gel and the toothpaste?
Traditionally, we're told 2 to 4 weeks. Now, it does depend on the product. So something with a bioactive glass might have a more long-lasting effect, but it might not work immediately. We say 2 to 4 weeks, but they should be regularly applied and not just used once every couple of days. So use twice a day, 2 to 4 weeks. However, Sensikin have found that their products have worked in 48 hours, and I know that there are other products that have active ingredients that have made similar claims. But again, the efficacy of any product is also dependent on patient compliance, not just in relation to their oral hygiene, but also their diet, particularly in relation to acid erosion. And I can't stress enough the importance of understanding the impact of acid erosion, because I see a lot of patients with gingival recession, but my first question to patients who have gingival gum recession is if they have sensitivity. I ask them about their diet all the time, and I think that's where there's a lack of understanding, is the importance of acid erosion.
Okay. How can the provitamin B5 be useful for most tissues?
Well, vitamin B5 there is evidence for its that it has a positive effect on the soft tissues, the oral mucosa, and the gingival tissues. But I'm not sure exactly how effective. I wouldn't be certainly promoting the Sensikin range for it. It's useful that it's there, but if I had a patient who had say, for example, sore gums, as I mentioned, I'd be looking at something like Kin Care, which has a hyaluronic acid and aloe vera. These are things that work more effectively. So although these ingredients are useful, I wouldn't be necessarily promoting those ingredients. It's useful to have them, but they're not my go-to ingredients in that product for the management of sore gums, for example. They have they do. You would probably be able to answer that a little bit better than me, because I don't promote the use of the Sensikin gel for that. I would prefer to use something like Kin Care for sore gums, and vitamin products are helpful, but I'm not sure exactly how effective they are.
Okay.
Do you want to add to that yourself, Susanna?
Yeah, I will just add that the main function of provitamin B5 is because it has itself, it's also known as panthenol, and it also has an kind of anti-inflammatory effect that helps tissue and also boosts collagen formation. So that's why it could contribute to reinforce gums. But as you said, I mean, the aim of the product is dental sensitivity, so it's an additional benefit for the product. Here there's another question, but I'm here. I think that is more addressed to our technical department, and is how much is the RDA of the toothpaste? The RDA of Sensikin toothpaste is about 60, maximum 60 RDA. Okay. In fact, most of our products are. All of our products are below this RDA, and we have even products with really lower RDA. Above all those products that has to do with gums. Okay, here we have another question for you, Dr. Alice. Is it better to use gel and toothpaste or gel and mouthwash for sensitivity case?
Well, I suppose as clinicians, sometimes it depends on the patient. Sometimes you throw everything at them because some patients can be quite difficult to manage, and there's no getting away from that. And I've done it myself. You open up the cupboard and you take out the gel, the toothpaste, the mouthwash, and you send them home and you say, try these, because it can be a bit of trial and error. And sometimes, even with the placebo effect, as I mentioned, if you give the patient the products, they think, well, this is going to work. And sometimes just with natural processes, they do work. Not just down to the product alone, but with a bit of positive reinforcement on your part. There's nothing wrong with giving the mouthwash to gel. I mean, the costs can add up for the patients, and so I wouldn't necessarily be routinely recommending using all three. I always start with one thing and then maybe add to it or change. So I would start with the toothpaste and the mouthwash initially, and then progress to the gel. I mean, it's more expensive. There's no getting around that. It's very effective. It's not expensive when it works, and it helps solve the problem. The patient is not coming back to you and back to you complaining of the problem. And so it's a good cost-benefit analysis to use that gel. But I'd start with the mouthwash and the toothpaste, but you could give them the gel as well. There's no harm in doing that.
Okay. And here we have another question. That is the Sensikin toothpaste useful for children, and which is the age that you would prescribe it to them?
Well, there's no reported sensitivity when we look on the prevalence of it. The studies don't show that it's a problem for children. So if a child has sensitivity, I'd be concerned that I'd be looking at their diet, because we know that erosion is becoming a bigger problem because of carbonated drinks, fizzy drinks. So my main concern there would be, why have they got sensitive teeth? And I'd be looking at wear on their teeth. I don't treat a lot of children. I don't know from the studies that I know from the studies that it's not a big problem for children. It's not a problem at all for children, really. But if you have a child and they are complaining of sensitivity, the first thing I would do would be to check, do they have dental caries? I'd look at my differential diagnosis. And if you're absolutely sure that it is sensitivity, well then, yeah, there's no problem in using it. But I'd be concerned about why they're getting pain from their teeth.
Okay, so we don't have more questions, but we had plenty of them, so that is because this is a subject of interest. That's clear. Thank you, Alice, again for your time, for your expertise. That was really amazing and interesting. And thank you all for being here, for attending this this webinar. It has been recorded, so we will send it to you through a link, so you can review again and have more knowledge about this subject. So thank you very much again, Dr. Alice. It was really a pleasure. And okay, for all of you, we will keep in touch, and we hope to have more webinars for more subjects of interest for you. Thank you very much.